One thing I didn't bring up that I actually had a slide for was this whole area of home care workers. I think many of us who have looked at the Bureau of Labor Statistics know that this will be, in the next 10 to 15 years, the fastest growing workforce. So a combination of people who are licensed home care workers and the people who are personal care workers. And this is the huge growth, in addition to some of the healthcare licensed professions. And this is an important opportunity when we think for a second about economic mobility. So you have physicians who are trained at 60, say anywhere from 13 to 16 years of post-secondary education, and then people who get certified after 80 hours of training. There's a big gap along the way here. And so if we're thinking about personal economic mobility as well as community economic mobility to mitigate poverty, the ability to think that there is, it's kind of like the missing middle class. Is there a way that we can begin to think about these opportunities? About 20 years ago, I was working with the state of California to think about geriatric aides specialized in nursing homes. And I got huge pushback by the California Nurses Association at that particular time, because they felt that we were taking away from their role. And so, again, what happens is, this is where that paper from Brookings is really interesting about, vested interests protecting their turf. And the fact that we've got to figure out ways to address this, and I'm just frankly very excited about that FTC paper to begin to have a systematic look at this about safety, competence, but then also access and all. And for systems like CareMore, which is an innovative Medicare Advantage plan in Southern California, about 7 years ago, I was invited to go visit them, and they were doing their post-hospital visits. This is before a lot of our formal transitions of care work was going on. They had, right after a person who was designated super high risk, they had a physician and a nurse practitioner go out and do a home visit within 24 hours. Highly expensive intervention on the one hand, right? But they did that because they really wanted to understand the environment the person was in, what they were capable of doing. And then they had a care coordinator who was a licensed practical nurse, did all the care coordination to do this. They were taught the skills to do this. And so the economic outcome of that was that they spent 67 cents on the dollar, so that their profit ratio was 33 cents, which is huge in terms of what they were able to do, because they were able to help stabilize their enrollees very quickly and use resources in a way that were a lot more flexible. So they were able to do this because this was an MA plan, and they ended up having some flexibility as to how they used their money. But this is, on the one hand, not new, but it has to be more diffused in terms of our producing good results for people as well as good results for systems. So I'll stop with that and be happy to answer questions, as I said.
Hi, I'm Marge Rotondo-Howard, and I'm from the FLHSA as a clinical advisor for the CMMI grant. And I'm wondering what your recommendations are to help prepare informal caregivers for the tasks that they are having to do now, and having to do in the future.
Sure. Well, there are free curricula. PHI is a national organization that really focuses on the direct care workforce. And on their website, they have curricula that's available for actually training individuals who are choosing to be workers in this direct care. So there are same things that are available for us as family members as well. But I also offer to you that ARP and UC Davis, University of California Davis School of Nursing, are actually putting out in this next few months a series of caregiver videos that are developed so that informal caregivers will have greater skill and confidence on this. So this is going to be publicly available very shortly, I'd say probably this summer.
So you're saying that we can recommend these sites to families as they're caring for their elder loved ones?
You know, I'm a little biased. I am a very hands-on person, you know, and there are a small percentage of people who are very self-capable, and, you know, these are people who do their own tutorials. Well, I'm not one of those that does that easily. I think there are actually some groups that need to actually come together. You know, even learning how to transfer somebody, learning it from a video is not anywhere as strong as getting that kind of instruction so that you kinesthetically get into the movement, or the pill reminders or something like that. So the ability to have, you know, whether it at certain centers or churches. You know, the Black churches have really mobilized their faith community to do this. So I think we just think about, where do people normally go and feel that they're in a social environment? And in some ways, you're learning some skill, but let's not make it also medical, or, you know, have it so that there's a real sense of social support. And so I think these videos would be helpful to talk together and practice. And, you know, one thing I didn't say when you were talking about thinking differently, back in 10 years ago, one of our colleagues, Michael Bly, who was a Robert Wood Johnson Executive Nurse Fellow, that's how actually Louise and I met, put out a paper with some colleagues called Wisdom at Work. And it's about this whole other workforce. Here we're talking about community workers and informal workers. You know, there's a lot of us who are so-called retired nurses who don't feel the need to work full-time or can't work full-time, but could do some of these things in a different way and could be engaged, you know, whether as volunteer or employed, because you know, a lot of people who hit Medicare will not need health care insurance, so as an employer you don't have to perhaps worry about that. But there are different ways to deploy extant resources, and this growing number of people who in the healthcare field just want to chill out a little bit. They don't want to have that high intensity, but some of this community education, training and all could really make use of people who have previous backgrounds. There's a paper put out by the SCAN Foundation of a study that was done by a group in Pasadena about six different roles that people could engage in that are more community-based. Some of it was transportation, some of it was medication coordination, some of it was care, you know, kind of care referrals and stuff, without being a full-fledged geriatric care manager. But you can do segments of work. So I think we've got to think about resources we're not even tapping on.
And just as a final comment, I feel like I'm a baby boomer. I've just turned the golden age. I'm still working full-time, plan to work full-time for a while more. But I'm also thinking about the future and what I can do to help my community.
Right.
So I've been thinking about that, but also really appreciate everything that you've said about nursing, advanced practice, and gerontology.
Right.
Thank you very much.
Yeah, that's the new plastics.
Hi, Jenny. Thank you for all of what you've shared. I'm a public health nurse, and I've been a nurse for 29 years this year. I love my field. I'm at a point where, you know, I feel that my perspective and my expertise is valuable, and I see that it's valued by others, and that's such a great feeling. I started out in the field of healthcare as a home health aide. It's how I paid my way through undergraduate school for quite a bit of the time. I have a very large extended family in the Rochester area, and so many women in my family work as PCAs, home health aides, and CNAs. I am well too aware of the job's dissatisfaction, the lack of commitment they have to their employers because of the work circumstances, changing from agency to agency, which affects quality of care, continuity of care, outcomes associated with care, and just so importantly, those who are served, they develop relationships with those who spend the most hours and have such a crucial impact on their well-being. But yet, their work circumstances are really going against that in so many ways. So I'm really grateful that you brought that up at the end of your presentation, and I feel that is so important. And so I just wanted to say that, and if you have any more to share about that, they're living at the poverty level, struggling to take care of kids, and these are all factors too that prevent them from being the best that they can be on their job, do the best that they can do for those who deserve good quality care in their homes, and it's affecting their quality of life.
I couldn't agree more. When I was running on law, and the bulk of our workers were direct care workers. And I'm so happy and proud to say that people stayed with us for decades. And part of it is paying a wage that was decent with good benefits. Everybody in the organization, from driver to direct care worker, got sabbaticals after 10 years. And basically about 3 months of paid leave to kind of renew and refresh. And they had a 403B plan so that they could retire. And so people, and they sat on the team. They were not people who just got orders. They were people who had observations. They had the intimate knowledge of the older person. They shared their interventions. Our drivers would pick up knowledge when they pick up somebody to come to our site. They could tell that their head was really wobbly or something, or they could tell they weren't eating their meals at home over the meals that we delivered. They'd report that, and the team there would pick it up and act on it. And it makes you feel that what you're doing is a contribution and makes a big difference to the work. So, a respect and a sense, a seat at the table, just decent wages and a sense of economic consideration, and a group of people that you liked working with, and all. It makes a huge difference, in that. But one of the things that's tough is if you're a sole provider at home, you're by yourself. So the ability to make sure that there's a way to help that person's skills be renewed and refreshed, and the ability to belong to something that's there, because it could be very solitary, even though you're doing fabulous direct work and you have a very close relationship with somebody. The ability to constantly have a sense of learning and belonging is real important.
Hi, Jenny. My name is Steve Newcomb. I work at the Monroe County Office for the Aging. Yes. I just have a question in regards to caseworkers in the community or direct care workers that are on a somewhat professional level, and you want them to mirror the population they serve, but a lot of times the job qualifications negate certain people from applying because they may necessitate a degree of some sort. Do you know what I'm saying? As far as that's discounting a large percentage of the population that could serve a population that they have an affinity for. So how would an agency go about addressing that issue, that impediment? Thank you.
Sure. Well, let me tell you what's happening in Detroit. The Henry Ford Health System, as well as its competitor, in Detroit, there are two big medical systems, Henry Ford, and I forget the exact name of the other, came together because they had the same issue of really worrying about being able to make sure that the community is a part of the health system, but that they're aptly trained. Well, they teamed up with the local community college and worked together in a way that, this is where it's co-opetition, so to speak, where you come together, and they've created a curriculum and job ladder. So real basic on the way. So they have actually created job training pool together for the community at large, and they have come together with the local public, educational system to start thinking about the kind of jobs that are going to be available in the community and help design this, again, from the ground up. And so it's been highly successful to bring two major competitors together to do something shared for a shared purpose and to bring jobs up.
Good morning. First, I just want to say thank you for your comments and also for your work with PACE. As a geriatrician and medical director for a PACE program for over a decade, it has changed my life and the people around me, and just thanks to you and your colleagues for starting this over 30 years ago.
Thank you, Dr. Case, for hanging in there for 10 years.
So my question really is to do with my training in public health. So 20 years ago, I went through public health school, and we learned about the demographic of aging. We learned about the rectangularization of the population. In 20 years, we've learned now that we will have a lot more folks with dementia. We kind of could have predicted that. We've watched healthcare costs skyrocket. We've watched the workforce, which you've talked about, of the people who we need to do a lot of the work decrease, and no real sign of improving. So my question really is more about how to look ahead and talk to the decision makers, whether that's the business leaders, the leaders of healthcare systems, our legislative branch, our executive branch, to help them really see that if we don't act soon, that tsunami will continue, and it will be much harder and much more costly to affect change 20 years from now. So you've worked in the policy arena, you've worked in a number of national organizations. What are the arguments that you feel like have really resonated and helped people to stop and change direction to address the age of the needs of what will be a huge part of our population, and someday, hopefully, God willing, ourselves?
Yeah, well, thank you. I'll use an example of what the nursing community has done. After the IOM report came out for nursing, one of the areas that was identified were the chambers of commerce. So precisely that ability to bring the business community into play, to think about what the economic viability of the contributions that a trained workforce would provide. So but it wasn't about aging, it was more about the nursing job role. But I think something similar when we, and part of it is there's nothing like somebody who's gone through that experience with their own family. When their own family gets hit, and this is what's happening, a bit more in Congress, that people realize even people with money and connections and all that still have the same core struggle, with a loved one who has Alzheimer's disease. So I do think that bringing these conversations and doing the storytelling, and incidentally, this work that I mentioned that's coming out of the 8 organizations, with AGS included, this whole aspect of how to do the narrative in a way that doesn't cause people to run away, So one of the things I actually learned, and I did it here only because you're a professional audience, all the data that the charts and things like that, you're telling people about this just turns people off, And so I wouldn't use this if I was talking to a regular community agency, gathering family members together. And so the art of the narrative is actually going to be a set of tools that are going to be important to capture, say, the interest of a chamber of commerce, the interest of people who are city council people, So the ability to start having the story, relate to somebody, coupled with tucking in a few key nuggets of data that might be relevant for a business or a policy voting type of thing. That has to be much more finely honed. And so there's some opportunity, and the information that will come out I think this fall from this group will be useful to use as metaphors. Because I actually just spoke last month or 6 weeks ago to the California Commission on Aging about this very thing, about ageism, and why doesn't the legislature take up some of these kinds of things. So they thought that this framing issue was going to be very important as part of the portfolio of work that we do to have influence on a community. But I think the financial component is real, and the idea of having enough money for other kinds of things like education and infrastructure and investment, a business investment, you know, is about how do you keep a community well.
Hello, my name is Regine Calvar, and I am a healthcare ethicist. And currently, most of the work I do is to advocate for families or patients. And currently, there is no reimbursement mechanism, so only people who have enough money can afford to have someone to advocate for them. I would like you to discuss or to explain how you would see that change in the future with this new model. Who would be doing the advocacy for patients? Who would be reimbursing it? How you would see this happening? Because right now it's really unfair for those who are the most vulnerable, have the least access to those things. And I really think that we need to look at the value of advocating for patients and for families separate from the typical medical institutions and how things are designed. Would you address that, please?
Sure. I think this unevenness is just kind of what we know to always be a struggle, you know, and so I know that's why the case, the Gates Foundation, is really thinking about equity in a broader way. So taking it from that perspective, I think the way those of us who are specialists and choose to democratize, as I've used the phrase, to bring it so that it's usable interventions for a family will be one of the things that we could do, you know, is how do we Home Depot ethics, advocacy. And so that's one aspect. But it also is so intrinsic in the fact that people who are professionals think that we are just the specialists. And so the ability to listen to the patient voice is the other thing that's a huge culture change. So I think we're going to be swimming upstream for a while, but the more gathered people can be, so whether it's if people belong to a faith community, having that kind of advocacy training and capacity building. They've done this in San Francisco, actually. There's a group that helps seniors know how to navigate and how to help another friend get through the system. There are classes that they take over a period of time, so they have new skills that they didn't. Sometimes they learn actually how to go online. So there is local work that could be done just to enable people to advocate for themselves better and perhaps also for a friend. So some of it's stuff that people just don't know about. Other aspects is the socialization of confidence, of knowing this, that you can do it, as well as you have perhaps the right to do it.
If I may follow up, I find that most of the people that I end up interacting with that need my services are people who suddenly find themselves in a crisis, health crisis, and the family as well as the patients are trying to figure out, do I quit my job? Do I just do this for a year and see what happens? Do I not quit my job, but then I don't know what's going on about this disease, and I don't know enough to know if it's serious, if it's 6 months, or if it's a 3-year type of deal, and it gets to be such a choice for so many caretakers as well as for patients, and not having enough guidance, not having enough support within the system that guides them and tells them, okay, the chances are, you have this kind of cancer, you have 1.5 years. So yeah, quit the job, live together, have a good time, or not. But not having that support in any way from any official organizations and reimbursement and looked upon as, oh, well, it's not really needed. I think it's really an issue because we really need to realize the values that we are bringing, and you can't really talk about not just equity, but access, unless everybody has access to that type of support and is made whole. And, you know, it's the hardest time to understand new disease, new research, new whatever is when it's hitting you.
Sure. Well, again, those of us who do this all the time, you know, have the ability to probably map out these journeys that people end up. And more often than not, all of us have found this. Probably in the back of our minds, we think about what's going to happen to our parent when something happens. And so you have a little small role play in your head, but you don't really actually do this. You don't necessarily talk with your family members about, gee, if mom suddenly has a stroke, you know, what are we going to do? So more of that is necessary. Some of you are aware of the Conversation Project, which is the national project going on, really talking about more the end of life kinds of things. I think it's a tool perhaps to talk about, gee, you know, so many, you know, older people end up falling. You know, what would we do is basically do a preliminary journey play with each other as siblings, or in particular, of course, with our parent themselves, but at a time that it's normal. And when I say it's normal, it might be one of their friends fell and things happened, you know, and the family went into this turmoil that everybody goes into. Use those learning moments to have those conversations, but we should have practiced this in advance, because it will happen for any of us. You know, our world turns upside down, and those kinds of day-to-day, let alone professional and economic issues really come out. So it's like anything else. It's you know, doing preventive teeth cleaning, people don't do this, or do financial planning, they don't do this. And this is part of the emotionality and age issues that we have. But I'd say that, you know, again, whoever that social group is, that person, that structure that it goes to, and I know that faith-based communities in some communities are not kind of a big support like they used to be, but for some people they may be. But are there other areas of socialization that are natural? And I think these are our trajectories and journeys. One of the things that we did at Unlock 30 years ago, we knew what the course was likely going to be, because these things were going to happen to people. So we gathered this conversation and talked to the older person themselves, found out they had 3 children, and figured out who was supposed to be the primary carer, and somebody else does the finance. But we did it when we were in non-crisis mode. So, and we would paint the prediction of what might happen if somebody broke their hip and it was so severe. It's possible the person needs to go to a post-acute facility temporarily, or possibly, depending on the healing, whether that would be, you know, long-term. And so the ability to cite and talk about the untalkable in some way, because their friends have gone through it. Everybody goes through it. We just don't articulate. So the ability to have these chats, whether it's when people come to visit during the holidays, natural times to talk about it, and seeing a whole bunch of medicines on the kitchen table, talking about, gee, you know. So these are things that are not easy to do, but certainly an ounce of that prevention really mitigates how big the crisis could be. So this is where it's secular. The professionals do the design of what likely would happen. Then it's really, I don't think it's every professional could do this, because it's stuff that we as Mary public can appreciate and understand, that every family has to do some planning, you know, on this, and have at least the conversation, so that you get a hint, you know. So many people will say, this would relieve you so much. My mother, you know, had talked about her dying. My father had talked about his dying. And it was not at a time that they were dying, you know, actively, but this would be the case. So when each one of them died, I felt a relief, a sadness that of course every child does, but a relief that I had honored their thinking and their wishes. And I've done that with my son already. So just getting that going early. So it's a gift to your family to be able to do that.
I work for Legal Assistance of Western New York, and we are a not-for-profit law firm that offers free legal services in areas of long-term care and health care, health insurance issues, seniors, and many other areas actually, but the ones that are most relevant here are the health care, health insurance, long-term care, and we don't charge for our services. We work very closely with the Office for the Aging and Lifespan, Catholic Family Center, Elder Source, which are also other places where services can be accessed to advocate for people needing and families needing long-term care for their seniors.
Well,
So I just wanted to make sure everybody knows that we exist. So thank you.
thank you very much. Yeah, legal issues are big, and fraud issues are very big. The IOM came up with another report on cognitive aging this past year, and it's sobering to realize the brain changes that do occur structurally in our brains, and that people who themselves have been highly accomplished professionals find that they too fall into this whole area, and they're embarrassed about it, having fraud and that kind of financial abuse occur. So it's, there's a legal side to this, but I'll bring up an institutional side. I think getting banks involved in your community to pick up patterns and who know their customers very well and find something that is a little odd, because oftentimes, that is, we know that unfortunately family fraud is really something that does exist. And because of our brain changes, sometimes that our judgment is going to be impaired, regardless of whether or not you have a PhD or, had been an attorney yourself in the past. So, yeah, there's just a lot that we have to do thinking about organizing our community, using available data and science that's coming out, and being a resource.
First, thank you so much for your provocative discussion of this really important issue. I'm Deborah Osterberg. I'm an advanced practice nurse. I'm with the FLHSA, working on actually practice transformation. And one of the, I think, more brave things that we're doing is looking at team-based care and having the courage to really encourage each team to look at all the members of the team, to encourage them to work to the maximum of their licensure and their training and their skill base, regardless and perhaps because of who they are on the team. So as you pointed out, we're trying to teach the skills and really shift the culture to help every primary care and specialty site, small or large, to work together, count on, trust each other, and engage in patient-centered work in that way. I really wanted to respond to the advocacy comment, the concern for advocacy, the concern for access of each family member and alternate care providers to access to advocacy, because I'm wondering if as we develop our workforce, as we develop our team-based care, there is opportunity for members of the teams that already exist to really develop their advocacy skills. And I'm thinking particularly of people like patient navigators, care managers, people who really are looking more broad-based, in a broad-based way at the patients and the family's needs, and people on the team who are in touch with coordinating care, understand the system, and maybe really well positioned to develop their advocacy skills. Of course, that's an intensive effort to advocate for each family because you have to know what's going on in the family, but I think as we develop teams, it's really our responsibility to think more broadly about what each role is and to include things like advocacy seriously in what we train and what we expect. So,
well, thank you. I think your point highlights for me just remembering, why do we do any of this stuff, you know? And the point of it is that we want lives to be better, and how do we contribute in that way? So it's not about us, about, you know, my personal license. Of course, you know, people work hard to get licenses and credential, but we're not the end point. The end point is, this is a vehicle to do something of public good. And so however we use our blessings, our talents, our licenses, and so forth, it's not that big of a leap to do the right thing. Okay, not just doing it right, but doing the right thing. Is their life meant to be better? And it's not about me. It's about how we pull together to make things happen. I always think about when we have natural disasters and earthquakes. You notice that people don't care. You know, people come together and get it done. And so if we kind of keep that framework in mind, is what if, you know, what if this was horizontal and it was just about getting something done for people? We could let go of those chips on our shoulders a little more easily.
Thank you so much. And thank you, everyone in the audience, for your input and for being here this morning. I think we really have a lot to chew on and to take back with us to work on. So
Thank you.
I'll conclude it here. Thanks to everyone.
Thank you.